So welcome to Quality Talk. It's a podcast that's dedicated to a better understanding of healthcare. I'm Primaris CEO Rick Royer, and I'm here with Marketing Director Rachel Versluis and Specialist Jody Jackson Jr. Rachel and Jody are the co-hosts of Quality Talk, which is today 1 year old, and happy birthday.
Yay, happy birthday.
It's really crazy that it's been a year already.
It is crazy that it's been a year, actually longer than that, since I started bugging you about starting a podcast. I started work here, I think, March the 2nd of 2017. And I think by lunchtime that day, I was saying, hey, Rachel, why don't I have a podcast? And I think I continued to say that for the next several weeks, months. And finally, Rachel's like, okay, make it happen.
I actually remember the birth of Quality Talk was finally one day. I said, okay, do it. And your eyes lit up. And then I said, I mean, you make it happen. But you've done a wonderful job.
Well, thank you. And since I am the one who sort of initiates from this point, and then Adam Voigt, one of our other marketing specialists, he does the production engineering and the sound work, and he does a great job with that. But I also, Rick, I'm the keeper of some let's say some very compromising recordings of Rachel, because to get her to say Duckbill Platypie, that was quite an adventure. So Rachel generally records the opening and the closing of Quality Talk. We record that separately after, like Rick, you and I would record an episode, and then afterwards that Adam adds Rachel's intro and outro, and so we record that separately. And those intro and outro recordings are usually only a minute or two, but those are some of the most entertaining. Unfortunately, we can't share that with all of our listeners. So maybe for an extra $29.95.
You can get the unedited version?
That's right.
I'll offer you $39.95 to discuss this after.
Okay.
So, is platypie the plural of platypus?
Actually, it's not.
It's not.
Platypus is the plural of platypus.
Mm-hmm.
All right then. So it's the same word.
It is.
I like that.
But, things you learn. And
yes.
I'll explain a little while later why we even considered.
We're talking about that on Quality Talk.
Well, I thought having a podcast in the first place was an interesting idea, because it's part of the new social media, internet, webinar-oriented kinds of things that are going on in the marketing sphere that old healthcare dogs like me don't know much about. And I think it's really, really got a home for itself, because I think you get a lot of listenership,
right.
And it puts our name and our brand out there so people recognize it, which is the goal. I think it's a fantastic idea and thing that we do there.
Well, in our journey to really become nationwide and help healthcare systems all over the U.S., we looked at the different marketing things we were doing, and one of the things that I'm so proud of being a part of Primaris is all the healthcare experts we have here. Not only that we have here within our company, but the other ones that we partner with or we have as clients. And so when we looked at all the ways we get our marketing message out there, the podcast seemed like the greatest way to have the furthest reach, to share all this expertise and knowledge we have in healthcare with everyone. But I kind of want to get Rick's impression on the podcast, because Rick has actually been the #1 guest on Quality Talk with a 9-time showing. So I'm just curious, how do you think Quality Talk's going?
Oh, I think it's great. I enjoyed being on. I didn't realize I was #1.
Number one?
I don't blame you, Jody.
You're #1.
And it's a joy doing it, because we've had diverse topics. We've had me on by myself. I was on with Dr. Lauren a couple of weeks ago, on with other people. So it's really been a good experience for me, because I've never done anything like it, and I think it's something that is selling.
I think so.
I agree. So I thought also I would share, why do we call it Quality Talk? Because I know I've had people ask us that before. And of course, as everyone knows, quality is at the core of what we do and who we are here at Primaris. We've been working in healthcare quality for more than 35 years. But from a marketing standpoint, it truly completes that trifecta for us. So some of you may know, and if you don't, you should subscribe, but we already have a newsletter that goes out monthly, and that is called Quality Time with Primaris. And then we do have our award-winning blog, which goes out weekly, correct?
Yes.
To our subscribers. And our blog contains all kinds of resources, white papers, tip sheets, video, you name it, that is called Quality Today. So we have Quality Today and Quality Time, so it just made common sense when we had a podcast that it would be called Quality Talk.
Yeah, and I really thought that that would be, one of the biggest conversations. How do we come up with a name for that? And I'm envisioning a task force, a work group, something like that. So I go to Rachel and I say, we've got to come up with a name for this, and she says, Quality Talk. Boom. Boom. There you go.
Remember, it's not that I'm bossy, it's that I have better ideas.
Okay, listen, I'm glad to be between you two.
I actually got her a pad of Post-it notes with that on it.
Is that right?
Yeah. So I remember who she's.
I'm sure she's treasuring them.
I'm sure she really is. Rachel, you skipped over the part here about when we launched Quality Talk.
Oh, yeah.
October the 30th.
Yeah, so we launched Quality Talk on October 30th, 2017. Our first episode was available on our website late September last year. But we hit a consistent ride towards the end of October, and we've continued to learn as we went along. By the end of the year, our Quality Talk was going out to subscribers everywhere. And maybe you can share a little bit, just like the different ways people can subscribe to the podcast.
Well, sure. The great idea of starting a podcast was sort of it sort of started out like the cart before the horse.
Maybe a little, yeah.
Yeah, because we were actually about 6 or 8 episodes in before we really realized, no, there's a better way to get this out there, and this is how we get people to subscribe. Ideally, you start a podcast, you should have all those ducks lined up. Because I thought, how difficult could it be to start a podcast? We'll record it, Adam will download it, do some editing, and we're done.
Easy.
Yeah, well, it wasn't on our website, but then how do we get it to subscribers? So it actually required starting a second blog because we use HubSpot for our content management system. And so the Quality Talk blog includes the show notes for each episode, and that is a listing, sort of an outline of our conversation that we have. It'll have a timestamp, like at 3:17 in the conversation, here's where Rick says something really profound. Here at 21 minutes is where Rachel stumbles over saying somebody's name, that sort of thing.
I will just throw in there, sorry to interrupt you, but I listen to a lot of podcasts, and I know that sometimes, I know ours are shorter, but a lot of them are lengthy, and those show notes have been huge to me, that maybe there is a certain topic or subject that when you see those show notes, you can go to the part that, maybe is the most interest to you, and then you can kind of get to that part of the podcast. So I think that the show notes are a great part to add.
Well, and honestly, the show notes they really drive our web traffic. There's an entire search engine, Google Analytics.
We cannot even start to make these guys' eyes roll back with talking about SEO.
No, but really that's why that's the one of the best benefits of the show notes, and helping people to follow along. But now you only get the show notes as the blog. We will call the Quality Talk blog our show notes. The Quality Talk show notes, you only get that if you subscribe, and you only get it if you go to our website. www.primaris.org. Rachel often says 4 W's, by the way. And you go to our website, and there at the bottom of the bottom left side of the homepage is the Quality Talk podcast link page. And you click on that, boom, there you have all of our show notes for each episode, and you'll also have a little subscription box. So you want to subscribe there, and then you will get that in an email when we send it out. We're trying to send those out now every Wednesday. We are also available on iTunes, and if you listen to us on iTunes, it would be very helpful if you gave us a review.
I'm a little bit biased also, but I think 5 stars would be a pretty good review.
5 stars. That's where we're starting.
5 stars.
That's all you got to do.
Yeah, just say you like it. It's 5 stars.
Suggestion, just a suggestion.
You can also stream Quality Talk on SoundCloud. So we do hope you listen, but the only way to get the show notes is to either come to our website or to subscribe. Rachel, I think that explains it.
Yes, it does. I did want to point out, earlier I stated that we really are trying to get a nationwide reach, and we're working with health systems all over the U.S., and we want to continue to do so. But I think something that's really exciting that we again stumbled upon in our experimental podcast here is that we're not just nationwide, are we?
We are technically international. We're international. For instance, Quality Talk had 62 new social media followers last week. Because one of the other really fun things I get to do here, and I have a lot of fun working here. So tell me if I'm ever having too much fun. And
oh, don't worry, we'll let you know.
Okay,
we'll let you know.
I appreciate that. But I also get to manage our social media, and that's been a hoot. It's a kind of a mind-blowing thing how much work that does involve. A lot of work that involves. But we had 62 new social media followers last week. 30 are in Turkey. I don't know what is resonating so well with our folks in Turkey, but we also had a dozen more from Australia.
Yeah.
So, Rick, I'm going to have to ask again, when are we opening a Primaris branch in Sydney? One of our guests for a two-part episode was Dr. Bernadette Ether. She's the Director of Clinical Quality and Patient Safety for the Ramsay Health System in Australia. They're the largest private health system in Australia. They have 73 hospitals. They have hospitals in France, Malaysia. But boy, Australia is a big deal, and we're getting people following us on Twitter, Facebook, LinkedIn, not Google Plus yet, because I think there's still only like 8 of us in the world on Google Plus. So I think Australia is calling.
Could be. Well, I want you to know that if Dr. Bernadette is interested in coming to work for Primaris as the head of our Australia division, we may have something to talk about. And I'm personally available to fly to Sydney to interview her. And I'm also available to go to Istanbul and check out this business in Turkey, see what's going on there. So you just let me know where we need to go to extend our global empire there, Jody.
Wow, I'm all aflutter with.
And to make sure that our messaging stays accurate at all times, pretty sure I need to go too.
Yeah.
Oh, yeah.
Okay, so let's come back to the conversation a little bit about, and talk about the nuts and bolts of what we do. You've probably heard if you've listened to any of our other podcasts, but we offer data abstraction services in core measures, registries, the very specific CMS web interface, which is the former G-Pro. We do MIPS optimization and work with a lot of health systems on their data in different ways. Rick, I'm going to throw this over to you, but first, Jody, tell us a little bit kind of about those first 51 episodes and how we touched on some of this, but also the different people you were able to talk with.
Yeah, I will, and I'll try to make this as brief as I can. You go to our website and find all of these episodes. You can go to SoundCloud or iTunes. But I want to tell you first about the next two after this one. Episodes 53 and 54 have already been recorded and will be coming out the first couple of weeks in November. Episode 53 is with Robin Benincasa. Robin is a 3-time Guinness World Record holder and a 10-time Ironman triathlete. And she's an adventure racer. It's one thing, I think, boy, it'd be really cool to be able to run a marathon or a half marathon. She does races that take 6 or 8 days, through the jungles of Borneo, the rivers of Fiji, those sorts of things. So you might wonder, okay, what does that have to do with healthcare? Well, I'll tell you what, Robin was diagnosed some years ago with stage 4 osteoarthritis. And she had total hip replacement twice. And she has metal hips. So she herself calls herself, she says she has bionic hips.
She's bionic.
Yeah. And so she does these incredible things. And one of the things that I really enjoyed in my prior life as a journalist was covering the MR340. It's a river race across the state of Missouri from Kansas City to St. Louis, basically. And they would stop along the way, little bergs just a stone's throw from here, and people would stop and they would take a break, or they would stop to check in with their time, and I enjoyed going and meeting with those folks. Well, Robin won the women's event for the MR 340 a couple of months ago. It's interesting, some of these folks finish in 58 or 60 hours or so. Robin finished in 38 hours. She didn't stop. And so she started in St. Louis, ended up in St. Charles area, and she set broke the record that she held. And in fact, her time is one of the top 5 fastest times, men and women. So anyway, she's got a pretty interesting story, and she's a very much in demand keynote speaker. She uses the term big, hairy, audacious goal.
I believe we've heard that.
Yes.
I think we've heard that here.
We've heard that here.
I wonder where we got it.
Now we know. Now we know. Okay.
So I had a great conversation with her, and that incidentally will turn out to be our first hour-long episode, and I think it's pretty engaging. And also after that one, then an episode with Dr. Kelsey Crow. Kelsey is a social work instructor at the University of California, San Francisco. She got her master's at Berkeley, or her PhD at Berkeley, I think. And anyway, she has started what she calls empathy boot camps that are really well geared towards folks in healthcare, oncology groups, physician groups, but also just anybody in any profession. The question is, what do you say to somebody when you don't know what to say, when they've had a terrible thing happen to them, or something really unfair has happened to someone you love? What do you say? Well, she has a personal, very compelling story about her mother just dealing with a pretty severe mental illness throughout her life, and Kelsey feeling at the age of 19 or 20 that she was really all alone, and nobody knew what to say to her. She just wanted to be able to talk to somebody.
Right.
So as a social scientist, she's actually done some research to kind of figure out what are some of the best things to say. And really the key is not what you say, but listen. And anyway, that is going to be a really entertaining episode.
Well, especially with the hot topic of patient satisfaction coming down the way, lines of new healthcare. Patient satisfaction, patient engagement, what is that doctor and nurse's touch point with the patients beyond taking good care of them?
Sure, and we talked about that. Folks in the medical field, you're not taught to kind of disconnect from your emotion, but you sort of have to in order to make good objective judgment and decisions, and you tend to shy away from much emotional connection sometimes. And so it's interesting that physicians are among the group that are the most lost for words when something terrible happens. We've had a number of people from our own staff. As Rachel said, we have so many, I think the buzzword in the industry is subject matter experts, SMEs, but we're very fortunate to work and relate to folks on a daily basis. We've had Kate Nagus. She talks about mental and behavioral health. Our claim program, they're the folks who do counseling for Medicare beneficiaries throughout the year, but they also right now are in the midst of the annual enrollment period for Medicare. Well, Tracy Wetzel and Karen Behan from that program have been on. And in fact, Carol has been on 3 times, and twice or 3 times now she has been part of a Coffee with Claim roundtable. Interestingly, I remember it's episode 27 because it keeps coming up in our analytics. It is our single most listened to episode. And her team of regional liaisons are talking about questions people have when it comes to Medicare.
Yourself or someone you love is dealing with that, so.
Right.
Well, and the interesting thing about that is, the claim program that we have is for Missouri, but the things that they talk about have an absolute national reach. So we've also had Vicki Alexander talk about data abstraction in our ECRO. Xavier Vaughn, he's a great public health educator, and he has talked about health literacy, social determinants and disparities. Scott Manea with the insurance counseling services. They're currently in the midst of helping folks sign up for
Marketplace.
Marketplace. Well, actually, that doesn't start until
right, open enrollment.
Yeah. And also from our team, Sharon Spotswood. She has talked about critical access hospitals. And then Robin Quarterman. Robin and I have done 3 or 4 episodes together. And our end of the year review episodes will be coming up, and those are really about too much fun, I think.
Robin is amazing at pulling all of our pieces together every day.
Robin,
She is.
she's brilliant.
Very
good. Alex Christian, who is the executive director of the Center for Patient Safety. We've had her on several times. Amy Parsons and Verna Gallagher have talked about core measures. What a great episode.
That was yes, core measures was a great episode.
It's very well received, and it really breaks down what they do. Tim Perkins talks about MIPS, and Mike Levenger, our chief operating officer, he has talked about the 7 stages of the health data life cycle. Now, our outside guests, it started out with investigative Pulitzer-nominated reporter Marshall Allen. We've had Dr. Sasha Shilcutt, and I would tell you that this morning I received episode 2 of the Brave Enough podcast. Dr. Shilcutt has started her own podcast, and it's really good. Dr. David Barr, president of the former president of the AMA, Dr. Pamela Weibel. We've had her on to talk about physician suicide, and I think we'll be following up with her. Christine Weary, lab technologist in Pittsburgh. She wrote Let's Put the Care Back into Healthcare. We've had Dr. Andrew Beck, Cincinnati Children's Hospital, Dr. Sunil Dand, who's really a world traveler and a physician out on the East Coast. He's also practiced in the UK and in Australia. And then Sue Jakes was an amazingly informative and fun conversation. Sue is a former medical examiner who is now a civility and professionalism coach. And that's a lot of fun. Dr. Haley Fisher-Wright, president of MGMA. We had, like I mentioned, Dr. Ether from Ramsay Health in Australia. Lisa Sunan, who's a healthcare venture capitalist, as well as a blogger and a podcaster. Dr. Monica Bertagnoli, the president of ASCO. And then Lauren Patrick with Healthmonics. I wanted to point out that our top 2 episodes on iTunes are Dr. Bertagnoli, one of the last ones we did, and Lisa Sunan. And that may have a lot to do with the fact that Lisa has a following of 100,000 people on her podcast. So I already told you about the next 2 that are coming up. I think we're on a roll.
I think also Jody just gave you, if you are new to listening to us and you haven't listened to us in the past, I think Jody just gave you a big rundown of a lot of good ones to go back and check out for sure. I've been so excited of the outreach we've had in only a year. You've really talked to a lot of great people in healthcare and moving towards the new way, so great job.
Well, why don't we bring the conversation back then to what we do and what we talk about?
Well, okay, episode 48 features Rick himself with our new partner, Healthmonics, founder Lauren Patrick. And 2 things that really jumped out to me, Rick, were first, you said that health systems are still struggling with interoperability issues. And I remember even after us helping implement 1,400 EHRs, you said we're still talking about it. Tell us more kind of about the work we did, and then what are challenges that are still remaining in operability?
Sure. Well, we assisted in the Regional Extension Center grant days of working for the Office of the National Coordinator of HIT, implemented EHR systems for 1,400 physicians throughout the state. We were the chief practitioner within the private sector, and there are a myriad of electronic health record systems by many, many vendors.
Right.
The list could be 100 for all I know today. Federal government did not start out smartly in requiring that they all have a common system by which they talk to each other, which is what the whole interoperability is about. And that has still plagued us to this day. The federal authorities are advancing interoperability standards, but it has been slow to the uptake. This has led to rollout of health information exchanges, which provide a vehicle, a utility by which you can move data from this hospital to that hospital, from this physician group to that insurance company, kind of like railroad tracks. but they have to work with this myriad of electronic health record systems, and no two of which may have the same types of access or ability to talk to externally. So it's a costly issue, and it's an issue that we have been dealing with. It's slowly becoming solved, but we could be 5 years ahead of where we are had this been managed properly out of the chute. So.
Well, I know even talking with our abstraction team, when they're first onboarding with especially like some of the larger ACOs that we work with, one of the hardest challenges is that they could, the same ACO could have 25 different EHR systems they're using. And so we know all those EHRs, but it's getting all the right data from all the places and putting it together. So I do think there's still ways of improvements to be made.
I suppose I should be thankful in a way that the situation is that chaotic, because we're one of the few companies in the country that can say we can deal with 25 or 30 different EHRs. Not everybody can do that. And so if you've got that, which is an operational pain to try to work through, we can at least get the work done. Right. And not everybody can say they can get the work done.
No, so all of our abstractors are former clinicians and well-versed in many different EHRs, so that is true. Job security, I like it.
There you go.
Well, I wanted to add too, the interoperability issues didn't end, agreeing with what you're saying, Rick, just sort of following up with the HIEs, the health information exchanges. That was seen as one way to get everybody, to run the railroad tracks from one hospital to the other. But I know one example is right here in our town, right in here in our city, two hospitals that are just a mile and a half from each other as a crow flies. They're on separate health information exchanges. So there's still some issues to
and they don't necessarily talk to each other very well. So those issues clearly abound out there. In the state of Missouri, we probably have a half a dozen different health information exchanges who claim to not be competing with each other. But there actually is, just this last week, an RFP went out from the state about putting together a master umbrella HIE for our state, which might be able to do that. But again, that's going to take a couple of years.
Yeah. Back to your conversation with Lauren, which I thought was excellent. When it comes to MIPS and quality reporting, you had said that a lot of health systems, ACOs and clinicians, they're all trying to kind of figure themselves out. Lauren even said, don't bury your head in the sand and hope it goes away. You offered the encouragement that there's really good help out there for you in this journey, and you don't have to be the deer staring at the truck coming at you. So elaborate that help that's available. And we kind of just talked about that with our abstraction work, but elaborate about that help that's out there for these guys.
Well, as far as MIPS is concerned, this is a methodology of working with physicians in establishing quality parameters and having them, if they remain in the fee-for-service system, be able to report quality and demonstrate their quality is improving. There's a lot of work involved with this. There's a lot of identification of those quality measures. If you're a large group, such as a client that we had that had 1,800 different physicians groups. You have to have a centralized system to coordinate that. We've done this, and we've done this being able to set up dashboards for corporations that manage large groups of doctors. We've worked with individual physician groups in helping them establish what do I need to do and how do I need to do it over the next few years in order to make sure that my paycheck is not negatively affected by the move to quality management. CMS, the Medicare Center, indicated originally that they wanted the MIPS program to fade into another type of a quality management or quality-based reimbursement program within a 5-year time period, and that would be 2023, somewhere in that area. My experience is that things always move slower and cost more than you think they will. So I think 5 years from now we will still be hitting the ball for MIPS. So we need to do that, because if physicians, as Lauren put it, bury their heads in the sand, by the time we get to that mature 5-year level, the difference between the doctors who make money and the doctors who don't is going to be 20% differential in pay. I would think that would get their attention. So we're there to help them. Please, it's a lot cheaper to do it now than it will be in the future. So pay attention to that.
Well, now if MIPS is just transitional, and like you say, in 5 years we should probably still be hitting the ball off this tee. but is there any indication what's next, the next phase beyond MIPS for value-based care?
Well, they would, CMS would like to see physicians be on either a capitated basis if you're a primary care with significant input from quality or meeting quality measures, to an episodic payment base that would cover several visits or things if you're a specialist. They break doctor payment into two different buckets. Hospitals would probably be on the same type of episode of care, maybe bundled with the doctors, maybe not. It would be very, very different than the 25,000 individual codes in the CPT book that doctors now bill in the fee-for-service world. Again, that's a 5-year goal, and there's, as you can imagine what I've said, just a lot of work that has to take place to be able to be there, not only from the architecture, but from the systems to be able to actually manage it.
Well, you know, I have I want to mention I have a 10-year-old nephew. I think he just turned 10. And he asked me, what do you do? He asked me, what does your company do? And I said, well, at first I said, well, I'm in marketing. And he said, so you like it's a store? I said, no. And
they sell stuff.
Yeah, so then I had to come up with this kind of the 40-second, actually with him it was more like a 20-second elevator speech to talk about what we do. And I took sort of a shortened version of what you just said and basically said, we're helping make healthcare better and hopefully less expensive. That's the eye on the prize sort of goal. Because the things that we do to get there is pretty complex, but it's intriguing.
Well,
we help. I mean, 2 words I think really sum it up. And when you look at the healthcare world, there are several parts. When you look at the QIO and the core measures, CWI abstraction business, and the assistance in moving quality measures forward in that scene. If we look at MIPS, moving quality measures in that scene, those are all moving together along the same path. Over here we have the Claim Program Foundation, which is helping individual beneficiaries as personal clients. We see over 60,000 Medicare beneficiaries as personal clients every year, and so that's moving healthcare forward in that respect. So it all works together.
And that's where, when we were working with our mission, vision, values, and it was something we truly talked to the employees about what they do every day and how they felt about what we do here every day, whether it was the insurance counseling or as mundane as abstracting data day in and day out. That's how we got to effective healthcare solutions to enrich the quality of life. Because whether it's helping those hospital healthcare systems do that through the data, or whether that's helping a consumer get the benefits they need and keep, that's what we do. We want to make it better for everyone with healthcare, especially with all the changes coming.
And there are a lot of changes, and changes in our world here, in the way that we get the message out. And the Quality Talk podcast is perhaps a prime example of that. Rachel just mentioned that the employees had conversations among and with each other to talk about our mission and vision and values. What are those? And that reminded me that not long ago we had another group of folks come in here, some examiners, who were asking our employees questions about our processes and the way that we do things, to help us. They're going to help us understand perhaps shortcomings, and they're going to also shore up our strengths of the way that we do things. And I was really hoping they would come talk to me, because
I don't know about that one.
First of all, I like to talk, but secondly, I came up with this thing that I thought was going to really be profound if they would come and ask me. So I want to say it here, right? And this is a great example of working at Primaris. One of the greatest benefits of working here is you have an opportunity to fail.
Yeah. And
for instance, this podcast, we started it sort of got off on a hiccup and, a little chug out of the gate, and here it's picking up steam and it's going. At some point, if it just wasn't working out, or if it was not a beneficial use of time, somebody here to the right of me, one of two people, probably would have said, hey, stop digging, you know. But I don't think it ever was a hole, and that is to me the best way to illustrate how the creative powers can be sort of unleashed and used here.
Well, that's really interesting you would say that, Jody, because I'm glad to see, first of all, that you know the first rule of holes. When you're in one, stop digging. But we have to do different things in order to move our company forward, period. And I'm more willing to experiment. I'm willing to do different things differently than we did in the past, because look how healthcare is changing every day of the week. If we don't keep up with those changes ourselves, we will be left behind. And so it's important that we encourage that type of experimentation.
I agree.
I think we have reached the end of our appointed time here.
I'm pretty sure all three of us could just talk forever.
Yeah, we could go on the rest
I know
of
you
the
guys
day.
probably all have jobs to get to.
Yeah, that's right. You might have something to do today.
We probably could. So I look forward to coming back here a year from now and saying, hey, we've been doing this for 2 years. We'll see what the future holds for us. Rachel mentioned earlier that we have our Quality Today blog. It does go out 2, sometimes 3 times a week. Every Friday we have the Healthcare News Roundup. And another thing that I sort of went rogue on and started doing, but each week we put links to and headlines from the best business report, our healthcare reporting for modern healthcare, Fierce, Stat, MedPage Today, Health Affairs, different bloggers and so on. And I think we get a real good representation of what's going on in the healthcare industry, especially as it relates to the work that we do and to the new world of value-based care. So look for that, especially on Fridays. It's called the Health News Roundup.
Yes. And thank you guys for
Very
listening
good.
and sticking with us for a year. We really appreciate it. We hope that you guys find this information valuable and resourceful. Give us your feedback and comments. I'm going to go ahead and give Jody's email address because I can do that. And it's jjackson@primaris.org. So JJACKSON@primaris.org. And if you guys have any ideas about other shows that may be great or that you'd like to hear topics more about, maybe even as yourself that has something to share in the world of healthcare and quality healthcare, just reach out to Jody and let us know. We're here to make things better for all of you out there in healthcare and give you the support you need. Again, if you do listen to us on iTunes, I will throw out there a 5-star review. Would be much appreciated for all of our hard work here. You can go to our website, www.3ws.primaris.org, and subscribe to our podcast there. Until next time, guys, remember that we are your partner in healthcare quality. Thanks.
Thank you.